So welcome to this session about expanding the clinical use. My name is VaniaBatista. I'm a medical physicist at Heidelberg University Hospital, and I will share our experience about using stereotactic body radiotherapy to treat patients with ventricular tachycardia. So I will start explaining what is ventricular tachycardia and how radiation therapy can help these patients, pointing out which are the requirements to implement this kind of treatments, then our workflow and some of our clinical cases. So giving an overview, what is ventricular tachycardia? So tachycardia, ventricular tachycardia is a heart rhythm disorder, usually called as arrhythmia, and is caused by abnormal electrical signals in the lower chamber of the heart, in the ventricles. It is a life-threatening disease, and these patients requires immediate intervention. So one patient with ventricular tachycardia can have several events a day. Some common therapeutic strategies are drug therapy, cardiac pacing, and catheter ablation. A new approach is a target of some of the clinical pilot studies is to use radiation therapy as a non-invasive technique to create cardiac ablation. To diagnose these patients, it is required to perform cardiac imaging to identify the cardiac areas with dysfunction. Based on this image, then we can, for example, perform the catheter ablation, that is the standard technique for these patients. However, still the recurrence rate is still very high, and additionally, you should remember that these patients have an implantable pacemaker or a defibrillator. So an alternative to the catheter ablation is, for example, to use stereotactic body radiotherapy. That will be a complementary therapy, for example, complementary to the drug therapy. And here your goal is to have a reduced toxicity level to the organs at risk. That is the reason why a single fraction is recommended with a high accuracy. Of course, that you should remember that a heart can suffer long-term radiation-induced toxicity. That is the reason why the high doses should be limited to a really small volume. Then you have additional difficulty that the heart is moving and the patient is breathing. So you need the high accuracy to moving targets. The experience, all the experience to treat these patients is based on some clinical studies, some animal studies, and some case reports. So the goal to use stereotactic body radiotherapy is to induce fibrosis at the ventricular tachycardia site. So to implement this technique in your clinical routine, is important to fulfill some technical requirements from the point of view of the target definition, treatment planning, and treatment delivery. For example, for the target definition, it's important to have some kind of electroanatomical mapping of the arrhythmia to identify where is the location of your ventricular tachycardia. That is, for example, this image where you can identify the location of some catheter ablation points and identify, for example, here in the red color, the region where you have now the current tachycardia occurring. Additional, then you also need some motion management imaging techniques, for example, a 4D CT. If you want to treat the patient in deep inspiration breath hold, a deep inspiration breath hold CT, and then define if you want to treat the patient with gating, with tracking. Of course, you also need a native CT for the dose calculation, and the studies point for a dose prescription of 25 grays to the PTV in one fraction. So regarding the treatment planning system, you need to have your treatment planning system validated and commissioning according to the guidelines to treat stereotactic patients and also to treat patients with cardiac pacemakers and defibrillator. There are several guidelines in different countries and international guidelines. Some, for example, regarding the patients with cardiac pacemakers, so it's important to ensure that the dose to the pacemaker or to the defibrillator is below 2 gray. You avoid high energies to reduce the neutron contamination. Your algorithm for dose calculation should be dose to medium, and you need to always to perform an independent dose calculation or the patient-specific measurements. Regarding the guidelines for stereotoxic patients treatments, it's important that your dose calculation algorithm includes a heterogeneity correction to account with the lateral electron scattering. You should use a treatment planning technique to have a sharp dose fall off. For example, use the VMAT technique, and you need to have an adequate small field dosimetry. Regarding the treatment delivery, it's important to define embolization and positioning method adequate to the condition of the patient. That means that the embolization can be based in surface guided, also or using a vacuum matters, for example. You need to define your motion management strategy. That for some patients can be deep inspiration breath hold. For other patients that have some issues and are not able to hold the breath, you can use the ITV concept. You should have 3D imaging in room, and during the entire treatment, because the patients can always during the treatment suffer some tachycardia events, you need to have access to the electrocardiography signal. For the treatment delivery itself, when surface guided is used as a method, you should ensure that the treatment planning system, the contour that you define for treatment planning system is representative of your patient, that no embolization devices are included. You need to adapt your surface guided QA for stereotoxic patients. That means that, for example, that your isocenter coincidence between the cone beam CT and the surface guided system should be below 1 millimeter, and you should confirm that there is no camera blocking effect higher than 1 millimeter. You need to define adequate ROI for to treat your patient, because you are going to use in this case a VMAT full arc technique. If you have an adequate frame rate to detect every motion of the patient, if your gating interface is working properly. Of course, it's really important in this case when you are using flattening filter beams, because you need to have a short delay time. And if for some reason you need to rotate the coach to apply a more conformal treatment, then you need to do a coach rotation QA also. Giving now an overview of the clinical experience at Heidelberg University Hospital, the first patient was treated in 2018 and was a success case, as the patient was so happy with the therapy that he inclusively gave an interview to a local newspaper. These are the clinical results for this patient, that the patient was treated. Here you can see it with these dashed lines after the 15th day that he arrived to the hospital, and after the treatment the number of ventricular tachycardia episodes decreased strongly, and the drug therapy applied to the patient was also reduced after the stereotoxic radiation therapy treatment. Until now, we treated our hospital 7 patients, 4 of them in deep inspiration breath hold. The dose was a single fraction of 25 gray. The target volume was a ventricular tachycardia exit site and the ventricular scar. And we tried to use deep inspiration breath hold using surface guided for all the patients that were in clinical conditions to allow it. This is an example of the patient number 2 that we treated at our hospital, and the CTV was then defined using the electroanatomical mapping, using the 4DCT information also to assess the motion from the breathing. The technique was to use the VMAT technique with 3 arcs, using a flattening filter free with 6 MV. The dose was 25 gray at the 80% ISO dose. with a maximum of 30 gray. The motion management technique was a deep inspiration breath hold using surface guided, and the treatment time was below 30 minutes, around 12 minutes for positioning and imaging and 10 minutes for the treatment. This is an example of, for this patient, of the free breathing CT, the comparison of the free breathing CT and the deep inspiration CT. Here you can see that the anatomy of the patient, that the heart position can change a lot. That is the reason why with the deep inspiration CT you can strongly reduce your motion and increase the accuracy of the treatment. For each patient, the plan was evaluated considering the dose for the different cardiac structures, as the vessels, the ventricles. The dose was evaluated in each region of the heart. About the treatment delivery and the imaging process, the patient is positioning using surface guided, then a combi CT is performed with the patient in deep inspiration breath hold. If some shift is required, a new surface capture is acquired, and then a second combi CT is performed to validate if there is a correlation between the surface and the tumor. To validate the positioning of the patient, also MV portals are performed, also in deep inspiration, and then the treatment starts with the monitoring with a line RT. The treatment is performed in deep inspiration breath hold with a tolerance from 3 mm and 3 degrees, and during the entire treatment there is an interface between the LINAC and the line RT, and if the patients go out of tolerance, the LINAC stops. This is the example of the treatment where you can see, because of the video function from a line RT, you can see quite well the patient positioning. You can monitor the patient during the entire treatment, and if there is any issue, you can easily detect and easily stop the treatment. Anyway, the LINAC is connected with the line RT, and the LINAC also stops if the patient moves. Simultaneously, it is important to refer that we have another monitor that has always showing the electrocardiography signal. We only treated 7 patients until now, and the patients were treated with different technique. Therefore, no conclusion is possible regarding the PTV size when using deep inspiration breath hold. It is possible to see that the ratio between the CTV and the PTV volume is kept below 40% when using deep inspiration breath hold, but factors as the quality of the available imaging data might affect the PTV size. More data is still necessary to draw some conclusions about this topic. Regarding the plan conformity, which was a requirement for stereotactical treatment, was for all the cases achievable, and this is the reason why for the majority of the patients we use a VMAT technique, and we got an average of 1.2 conformity index. About the organ at risk, the mean dose to the heart was between 4 and 9 gray, with negligible doses to the implantable cardiac devices. The CTV coverage was for all the DABH cases above 26 gray. Regarding the reproducibility of the deep inspiration breath hold, of course, as our results are only based in 4 patients, but we verify that the variation between the correlation tumor surface between the planning CT and the combi CT was around 7 mm in average. But if you look for 2 combi CTs, because for all the patients we required a combi CT, we moved the patient and then we require a second combi CT to confirm if the correlation between the surface and the tumor is kept. Then we got a variation always below 2 mm. So in resume, deep inspiration breath hold might contribute to a reduction of the irradiated volume. Using surface guided is feasible for monitoring, and image guided by combi CT. Treatment planning, LINAC, and workflows must follow the requirements for stereotactic treatments. Clinically, we verified that the ventricular tachycardia decreased for all the patients after radiation therapy within 2 weeks. Some patients had a long-lasting effects, and the antiarrhythmic medication could be reduced. The treatment time was always below 30 minutes. So thank you very much for your attention, and I will be glad to answer your questions.